2007, graduate of the University of Pittsburgh School of Pharmacy. After graduation, he completed his PGY1 residency at Fifth County Memorial Hospital, which is affiliated with East Carolina University in Greenville. Thank you. He's currently a clinical professor at the West Virginia University School of Pharmacy, an adjunct professor at the WVU School of Medicine, and an internal medicine clinical pharmacist at the WVU Medicine Roofing Memorial Hospital in Morgantown, West Virginia. Dr. Wietholter is involved in many aspects of the WVU School of Pharmacy curriculum with over 70 contact hours annually, and is also the coordinator of 3 School of Pharmacy courses. That's the Health Systems Pharmacy Practice, the Neurology Psychiatry Module in the System-Based Therapy Sequence, and Travel Medicine and Global Pharmacy Practice. He has over 30 publications, including peer-reviewed journal articles, textbook chapters covering a wide range of topics, and has presented at both national and international conferences. We have Dr. Wietholter, who is also a fulbright specialist, and he's visiting our institution to help us in the development of our integrated modular curriculum. He has developed and coordinated an international advanced pharmacy practice experience in South Africa, completed by 4th year WVU pharmacy students. Dr. Wietholter is married to one wife and has 3 children. So I have the pleasure of inviting Dr. Jon Wietholter to give us the topic. Thank you.
All right, good morning, everyone. Thank you for being here today. I'm going to be a little patient here. Those of you that have seen me teach know I walk all the time, don't I? So I'll probably be pacing back and forth up here as we give this talk. But first of all, I really appreciate the opportunity to come and speak with you today. I was excited when I was sent this topic to talk about, because I think this is something that, as the 2 previous speakers mentioned, pharmacy is ever changing. Right? The world's changing, education's changing, pharmacy practice is changing. And it starts with you in the classroom. So pharmacy education, what's changing within the way we're delivering the education to you as students, and what are some exciting things that are happening within the curriculum that students really tend to enjoy when they're going through the curriculum. Okay, so through the course of this lecture, my goal is to hopefully talk through some of the things you might find a little more boring, all right, the more foundational type things of how pharmacy education is changing. But also I'm hoping to highlight a couple of the interesting components, 2 in particular that we put into play at the WVU School of Pharmacy: some educational gaming, so gaming within the classroom, and also some simulations. Okay? We really tried to expand upon those since we changed our curriculum back in 2017. So we went through the same process that UCC is going through, where we went from a more siloed curriculum into a more modular curriculum, where we were trying to combine a lot of different components from each body system into one particular course. So I'll talk through some of those components here as we're going through this lecture. So first of all, when I was provided this topic, I reached out to 4 fellow faculty members. I work with some great faculty members at WVU School of Pharmacy, and I want to make sure I thank these 4 women first, because they are phenomenal in what they do. I chaired the curriculum committee for 3 years and was followed by Dr. Berrickman, who has now been followed by Dr. Galvez. So we've been heavily involved in curricular development and monitoring of the curriculum at WVU. Dr. Wetzel in the bottom left is a big TBL-based proponent, and she's really who I learned my style from. And Dr. Stamatakis is our Associate Dean of Educational Affairs, so she oversees the whole curriculum. So these 4 women help with providing some of the concepts that they thought would be important to cover. And in fact, with Dr. Wetzel, I just stole some of her slides. I asked her for permission, but I just stole some of her slides. All right, so objectives. What are the 5 main things I want to cover over the next hour? Really, I want to review the potential benefits and mechanisms to integrate activities within a school of pharmacy curriculum, or even the structure of the school of pharmacy curriculum. Hopefully, I'll be able to demonstrate understanding of the benefits of team-based learning, TBL. And again, the level 400 and 500 students, I forced you to do this over the last couple of days. So you probably have a little more insight into what we're going to be talking about here. But also, how do you design and carry out one of these sessions? Next, I'll describe some potential educational gaming opportunities and hypothetical benefits of them, including creation of increased active learning opportunities for students. So what you'll see is, particularly within our curriculum, we're going away from just the faculty member talking to you as you're sitting down in your seat, right? We're trying to get students more involved, we're trying to have more active learning opportunities, and we're going about multiple different ways of doing so. Next, I'm going to summarize the curricular outcomes and entrustable professional activities that were updated in 2022 and why they were developed. That'll be a little bit of a quicker summary. And at the end, I'd like to show you, and hopefully at the end, this will be able to prepare a simulation-based activity that can increase student engagement by forcing them to get a little more hands-on and more involved. Okay, so those are the 5 things we're hopefully going to cover. So first, we're going to talk about an integrated curriculum. And that's, like I said, that's part of the reason I was brought here as a Fulbright scholar, was to work on finding those potential areas of improvement and highlighting the already existing areas of strength within the proposed integrated curriculum that UCC will be transitioning to. So I've told the students I've lectured to, what's my favorite question? Why, right? If you can't answer the why, then you don't know. So I want to make sure we understand the why we're doing a lot of these things from an educational change perspective. So the relevant literature behind integrated health professions curriculums, ultimately these integrated curriculums are designed to produce graduates that are ready to address certain current healthcare needs of your population that you're serving. Hopefully they'll also, the graduates will be able to retain knowledge and acquire pertinent skills that will allow them to practice at the top of their license. And also, we're hoping that our graduates will be able to apply skills and knowledge to solve more complex problems, right? Not just simple, straightforward, what's the dose of lisinopril, but what patients should get lisinopril, what patients shouldn't get lisinopril. Those are the types of things that we're really hoping to get them to that next level and apply the information we've taught. Now, what does the literature tell us? What are the outcomes? Are we just doing this with no basis behind what actual benefits students get from these? No, we're not. The outcomes that have been shown, most studies have showed that students have very positive perceptions and also a higher level of satisfaction with an integrated curriculum. The literature has also summarized that this type of curriculum helps improve attendance and communication skills. Part of that is we're forcing communication in the classroom. Right? With team-based learning, you're forced to talk to your classmates next to you to come up with answers. There's also been knowledge gains and improved exam performance noted. So there have been benefits from a knowledge perspective. And students have also reported having increased confidence and motivation. So we have some support for these integrated curriculums and that they can help students in a lot of different ways as they go out into pharmacy practice. So here's our example of, my example of our integrated curriculum at the WVU School of Pharmacy. So our first, one big difference, and I'll let everybody know, we are a 4-year School of Pharmacy. The first 2 years that you guys complete in your School of Pharmacy, for us, are completed at the downtown campus. The pharmacy school doesn't control. So I don't want you to think that our students graduate after 4 years and you're going 2 extra years. It takes 6 years to get through pharmacy school in the US. Our first year of pharmacy school is really designed to provide a foundational knowledge base. Students get a lot of biochemistry, anatomy, physiology, a lot of those foundational components that you have to understand before you get into the more clinical courses. Now, our second and third years are primarily therapeutics-based, and that oftentimes ties in with our systems-based therapies. Okay, so our systems-based therapies, or SBTs, are our integrated component, where while they're therapeutics-based, there is still a heavy focus on the foundational sciences. And we'll talk about what exactly is contained within these on the next slide. So as you can see in our P2 fall semester, we take a course called pulmonology. So that's respiratory-based drugs, respiratory-based therapeutics, respiratory-based medicinal chemistry, respiratory-based pharmacology, all within one course. And typically what they will do is, what we will do is we'll have a day of foundational sciences on a topic, followed by a day of therapeutics on that same topic. So I teach pretty heavily in pulmonology, so a great example of that would be COPD. One of my fellow faculty members, Dr. Gilden, will come in and he'll talk about the foundational sciences component on Monday, and I follow that up on Tuesday with the therapeutics and trying to tie some of those loose ends together. So when you walk out after those 2 days, you've had all of these different components about that disease state, so that hopefully you feel pretty comfortable with that management of that particular disease state from multiple different viewpoints, okay, both foundational and clinical. So as you can see, it trends through pulmonology and cardiology, P2 fall, P2 spring, pain, nephrology, autoimmune, and endocrinology, P3 fall, infectious diseases, GI, and neuropsych, which is of course I coordinate. And then P3 spring, we've got oncology, special populations, and then our capstone course, which I'll talk about here in a second. The fourth year is nothing but practice experiences. So it's very similar to your structure here, and that you'll be going out and practicing in hospital settings and ambulatory care settings to really, again, apply everything you can taught in the classroom to patients. Right? We want you to be able to walk out with your pharmacy degree, go out and positively impact patients. That's the ultimate goal of any pharmacist. So these SPTs meet 4 to 5 days per week, with all students assigned to 1 2-hour practicum session per week. So our practicum is really designed to, it's not a lab per se, but it's where we do a lot of the lab type activities, or maybe our simulations that we're going to talk about, or our patient cases that we're going to talk about in a second. Okay, so that's where we're coming from. That integrated component is really important to us because it ties in a lot of these different topics. So what are those topics? These 3 statements are on every single syllabus in our systems. Okay, so the students know each team taught course integrates the biomedical and pharmaceutical sciences with the sciences, pharmacotherapeutics, and pharmacy practice skills. And these courses, the content that we're going to cover includes medicinal chemistry, pharmacology, pharmacokinetics, pharmacogenomics, toxicology, pathophysiology, pharmacotherapeutics, nutrition, wellness, population health. Am I overwhelming you? Right? That's a lot of stuff in one course. But if you design it right, it makes sense. Okay? Because you can tie all these things together because you're talking about them all in one tight little package versus in multiple different courses across the year. Additionally, we state the syllabus after completing the course series. Students will have the knowledge and skills to apply scientific principles when selecting and monitoring drug therapy in various practice settings. So what does that mean? That means we're using all that foundational information to help us in patient care. Okay, the ultimate goal of an integrated curriculum. So one way we do this is through multiple integrated activities. So from our integrated activities, one of the things we do is patient cases. And what we do with these patient cases is we assign you a patient in a computerized health record. Your job as a student is to then go log into that health record, collect all the information you need to figure out what's going on with the patient. We don't tell you anything. There's no lecturing. There's nothing going on. It's you logging into the computer and figuring it out on your own. And with that, we're trying to enforce the fact that you can go through multiple steps to get to what you need to, both foundational and clinical in nature. So students will usually complete 1 to 2 patient cases per SBT, with them being completed as groups in their second year. So usually you're working with a couple other students. But when you get to be a neuropsych in your 3rd year, it's all individual. So we're testing to make sure you know how to collect data, how to assess data, and how to come up with a patient care. And I wanted to highlight that this doesn't always have to be clinical in nature. We can really prod for foundational sciences components, things like mechanisms of action, explanation of adverse effects based on physicochemical properties of the drug, or even some pharmacogenomic concepts. Right? It does not have to be just therapeutics within these patient cases. And we try really hard not to make them just therapeutic based. So again, enforce that integrated component. On top of that, my favorite question, why? We make students argue why they made their recommendation. So you can't just pick a drug without telling us why you picked that drug. And a lot of times when you're providing that justification, you're going to say it's because of this specific mechanism of action or this specific target affinity of the drug. So again, trying to tie in those foundational components into the decision-making process. Students are ultimately evaluated on the appropriateness of their recommendations, right? We want to make sure they're making the correct recommendation, but we're also really heavily looking at that justification and making sure they can answer the why behind what they're doing. So just a real brief example, I'm hoping you can see this. This is from my case in neuropsych. So we create a grid, and along the top you can see what they're responsible for. Patient problem, identifying the problem, goals of therapy, therapeutic recommendations, and monitoring. So what you'll see is this is a patient that I designed within the computer EHR that was struggling with atonic epilepsy. All right, drop seizures, falling out seizures. So the patient chart, when they waded through it, they should be able to figure that out. And when they do that, box number 1 up here, they have to come up with atonic epilepsy as the problem to get that answer correct. For the goals of therapy, I provided them the goals of therapy here. They didn't have to specifically come up with that, but they did have to come up with an appropriate recommendation. So you can see box number 2. This is where they have to come up with what medication are they recommending to help this patient from an atonic epilepsy perspective. From a monitoring perspective then, I gave them the efficacy monitoring perspective, but from a toxicity perspective, I wanted them to argue with this medication that I selected, these are the side effects that I would be monitoring for the next time that patient came to see me. Okay. So it forces them to think in multiple different areas. And there's ultimately 10 questions that we ask for in these cases. So we have them collect data, they have to figure out the subjective and objective information. They have to identify problem number 1, which we already did, right? Atonic epilepsy. They have to provide their pharmacotherapeutic recommendation and provide appropriate toxicity monitoring parameters, all for problem number 1. Now, how many times will you see a patient with one problem? Never. Never. The answer is never. Patients have a ton of problems usually, okay? So I would say the typical problem list that I'm forming for my patients on an internal medicine service, we're looking at 8, 9 different disease states we're taking care of. Now, if we force the student to solve all of those problems, it would take them longer than the 2 hours to get them on there. So we try to narrow it down to 3 different problems. But what I want to highlight on the next slide is question number 6. So how do we tie the foundational sciences component in here? We tell them you have to provide a summary of the mechanism of action, like the drug you selected, and assume an 8th grade education level. Okay, why did I put that in there? I want students to be able to explain the mechanism in patient-sensitive terms, so that when they're explaining that to their patient in the future, the patient will be able to understand it. Right? In West Virginia, where I'm coming from, our medical literacy amongst the general public is poor at best. So a lot of times when we're talking to our patients and counseling our patients, it needs to highlight these things at a lower education level to make sure they're grasping what you're doing. You can also integrate exam questions. All right, so here's an exam question where the students had to find a beta blocker for a patient diagnosed with hypertension. All right, we won't go down the road that beta blockers aren't great for hypertension. All right, so probably not first line agent, but you need to pick a beta blocker for a patient diagnosed with hypertension, and you're given these 4 chemical structures. You're also told the patient is being treated for COPD. All right, so are we tying a lot of different components together here? Yeah, they got to know what a beta blocker looks like from a medicinal chemistry perspective. They've got to know what they're looking for, right? If they have COPD, we're probably looking for a beta-1 selective beta blocker, not a non-selective beta blocker. And you got to figure out which of these that actually is. Okay, so your integrated exam questions can cover a lot of components too. So this is a great way to reinforce the fact that medicinal chemistry actually plays a role when we select drugs. Right? Okay. All right, so that's the integrated component. The next thing I want to highlight is team-based learning in the flipped classroom. So again, a big move towards active learning within the School of Pharmacy curriculum. So one of the ways we best know how to do this is through TBL in the classroom because of the data behind it, and also it's something that we've been doing at WVU here for roughly 10 years. So it's something we feel pretty comfortable with. So what is a flipped classroom? So most of you as students are used to a faculty member coming into your classroom, lecturing for 2 hours, and then you've got to study it to get ready for the exam, right? And that's kind of the standard teacher-student relationship. This is called flipped classroom because that's flipped on its head. So the direct instruction, the direct lecturing, the direct component of your learning process is actually done before you show up to class on your own. Done before you show up to class on your own. Then when you come to class, we're going to work as faculty members assuming you have that baseline foundational knowledge. You've got it. Okay? Because we've already given it to you via a reading or via a recorded lecture of it. So class time is then used for higher order active problem solving by students with interactions with the educator. So there should be a lot of discussions in these sessions. You should not just be sitting in your seat not saying anything. There should be a lot of back and forth, a lot of Q&A between the instructor and the student. So basically what happens here, the typical lecture and homework concept is reversed, right? You've got to come prepared based off of what the faculty member provides you and then apply it in the classroom. And this is considered a very learner-centered educational model. A couple of things it is not. It is not a method to allow more time for content. When you come to class, we shouldn't be giving you new content. It should be covering all the same material that you already had handed to you before. It is not easy to implement. So from a faculty member perspective, if this is something that intrigues you and you want to endorse it and you want to use it in the classroom, don't think that it's not going to take a lot of time to implement. Because that first go around trying to switch things around, it does take a little bit of time. It is not less work for the instructor. I can guarantee you that it's not less work for the instructor because you have to be up to date when you're providing that recorded lecture, and you also have to be prepared for the most off-the-wall questions from students. All right? Every question that you think you're going to get asked, you probably won't get asked. What will you get asked? The one you have no idea about, or one that you never would have thought of. But sometimes that's a good thing, because sometimes the student's asking a question that actually helps your thought process as a faculty member go a different direction and start thinking through, okay, maybe I need to start teaching on that component a little bit more. It's also not a guarantee that anything different will occur during class time. I hope students are engaged. 400, 500 level students here have been unbelievably engaged in the classroom. I love it. Some days with me, with my WVU students, it's like pulling their teeth to get them to talk to me. They just want to sit there. Okay? So you have to try to make class enjoyable enough that the students want to be involved and want to get involved. It's also not for all educators and students, and it's not for all subject matters. Right? You can't do this style with every single lecture concept, and not every educator is going to be comfortable with doing this. Okay? So this is usually an individualized discussion between faculty that want to give it a shot. So why do we do it? Again, to answer my question, why? From an advantages perspective, with students, it has shown improved academic performance, increased engagement in the classroom. It does appear to enhance critical thinking and provide an improved attitude towards learning in general. It can enhance skill building, and it also emphasizes the fact that lifelong learning is important. When you walk out of here, you can't stop learning after your 6th year. Okay? You've got to stay on top of the literature. You've got to incorporate that new information into what you're doing. And it also enhances teamwork. It forces you to work with students in your class, come to a solution together, and then discuss that solution with the rest of the class when you come back together. From a faculty perspective, it's improved job satisfaction, a better academic performance tied to it. So students are happier with this type of curriculum, and their academic performance improved. It seems like a win-win situation. So there have been some critical appraisals of the classroom and medical education literature. And the consensus that they've come to is that it likely will result in greater procedural competency and knowledge. It's at least non-inferior in terms of general knowledge acquisition. It is beneficial for higher level, higher cognition tasks. So hopefully it gets students to a higher level in their education. And promotes superior student engagement. However, this does require very high quality pre-class material. So the faculty member has to figure out how to make sure the students come prepared to the classroom. And as we all know, some faculty are better than others at recording lectures, some faculty are better than others at picking appropriate readings, whatever route you want to go. So you have to make sure that that pre-class material is high quality. These are general principles of effective teaching and learning. So there should be improved student-teacher interaction. Does TBL do that? Yeah, of course it does. And that's part of the main process behind TBL. Does it provide opportunities for real-time feedback? Absolutely. I told the level 400, level 500 students, these class sessions are where you can miss things, right? You can make mistakes in the classroom when we talk about this. It doesn't impact the patient. Can't make those mistakes when we're out taking care of patients. So this is the time where students can get real-time feedback that, no, that's not correct, but here's the positives behind that answer, and here's why I would go a different way. So you do that in real time. Student engagement is important. Does TBL force that? Of course it does. Yep, we've highlighted that multiple times. It also allows for self-paced learning. Okay, so in my recorded lectures, they're all 1 hour or less, or right around 1 hour. But if you have a student that really wants to dig into it and really want to wade into the data and information that's being provided, and they want to spend 3 hours on it, they can. Right? It allows them to spend more time on it. Now, I'll tell you what our students do. With our recorded lectures, there's a fast forward button, and it makes you speak at double speed. So I sound like Alvin and the Chipmunks, but allows them to get through it in 30 minutes. So guess what our students do? They do that, right? So it allows that for them if they want to speed through a lecture, but hopefully students are taking their time and really wading through the material. And it also provides targeted in-class opportunities to practice skills. So there's really 9 design principles for the flipped classroom. I'm not going to highlight these too much for the sake of time, because what it usually comes down to is what's on the next slide. And that's when you design it, you have to provide students with learning objectives. You have to assess whether or not they know the material. And you've got to do that usually through activities in the classroom to force them to interact together and come up with those answers. So from the pre-class preparation perspective, these are some guidelines. You're supposed to use a 1-to-2 ratio for in-class to out-of-class time as a general guide. So if we have an hour and a half in the classroom, we should estimate that they'll need 3 hours of out-of-class time. So it puts the evidence on the students to put the time in out of class so that they can make the most of those in-class sessions. The pre-class activity is at a 0.5 to 1 ratio. So really what they're saying here is if you have a 3-credit hour course, you do need to consider frequency of quizzes. So one of the big drawbacks to my material, and one of the things students complain about every year, is they hate having exit quizzes every class. The problem is, if I tell them they don't have an exit quiz, are they going to come prepared? Probably not. Right? Our students, probably not. So with that, I really try to reinforce the fact that every single topic we talk about is really important. You can do pre-class, in-class, and after-class assessments. Like I said, mine's at the end of my section, an exit quiz. What you could do is do a quiz at the start of the class section and make sure they watch the lecture before you even talk about anything. Okay? And again, that should probably be take-home points. Feedback should be timely, and again, it's really important that the instructor should clearly communicate expectations and specify how the assessment will be evaluated at the time it is assigned. So day 1 of my course, I tell them, you got a quiz every day. Buckle up, it's going to be tough, it's going to be difficult, but we're going to have a quiz every day. Okay? And that gets them in that mode of trying to build their schedule around that particular course. And again, being cognizant of the instructor and student time is really important. Okay? So the TBL component, that flipped classroom, is designed to force you as students to get more involved in the classroom, to be involved, to be engaged. Some students love it, some students hate it. I will tell you through the years, more students love it than hate it. And it's been a good shift for us at WVU. All right, so we talked about a couple of more foundational curriculum type things, the integrated curriculum and TBL. Let's talk about something that's probably a little more exciting, and that's the use of educational gaming. Okay? Having students play games in the classroom. Does that sound fun to anybody? Yeah? That'd be exciting to play a game in the classroom. All right, so what's the literature behind it? Are we just doing it because I'm a gamer, I like gaming? No, we're not, right? We're doing it because there's some literature to support it. So, educational gaming and pharmacy. This is a method of active learning that makes non-game-based material into a game within the classroom. And it's designed to help prevent inattention, particularly during long class sessions. So a lot of times what we'll do with these gaming components is we'll plug them in at 30 minutes or at an hour or at an hour and a half. And students are really starting to lose their attention span. And that attention span, as generations are going on, is getting shorter and shorter thanks to cell phone. So sometimes we'll need to put these educational gaming components in a little bit more frequently. These are often low stakes, and they can provide instant formative feedback. Okay? And you can make them flexible and adaptable as a faculty member. You can have them highlight any particular thing you want them to highlight. It can be utilized, they can be utilized in almost any area or discipline of pharmacy education. You can make it a medicinal chemistry educational game. You can make it a pharmacology, pharmaceutics, a clinical therapeutics educational game. It can really go any way you want it to go when you're designing these. And it's likely best for application-based use, or sometimes it's best for things that students find uninteresting. Right? Students don't enjoy learning about laboratory values, right? And memorizing numbers. Well, you can create a game out of that, and we're going to go over that here in a second. It doesn't necessarily require high-level technology. What we use within the two main ones that I'm going to highlight today, it utilizes Google Drive, and it utilizes a $20 lifetime membership to a Jeopardy game. Okay, so we've had faculty members pay for that, and then they just utilize it on a yearly basis. Now these games, again, students are going to probably enjoy it, right? Because it's not the typical learning style, but it also has been shown in the literature to improve student confidence and again, improve student engagement, get them more involved in the classroom. And it can aid in preparation to give them practice skills that they'll be utilizing in a real world setting. All right, so let's look at a couple of these education gaming opportunities. So one that we utilize is a virtual escape room, and we're not going to have time today to actually go into the full escape room to show you what it is. But one of these escape rooms is to integrate pharmacology, medicinal chemistry, pharmacokinetics, brain engineering aids, clinical practice guidelines, and counseling aids. And the spot we use this as a WVU curriculum, this escape room, is for them to escape from the cardiology company. They have to complete the escape room to get through cardiology. And what it is 12 different activities where they have to figure out some clues and some context clues to come up with codes or answers. And they will then move on to the next part of the escape room. An incorrect answer, they don't move on. All right, so they've got to figure it out. It takes them, we give them an hour to get through it, and we provide some incentive. The top 2 to 3 groups that complete the escape room get to pick which practicum they want the next semester. Okay? We have an 8 to 10 in the morning practicum. They don't want that one. Right? So if they can win this escape room, they can get the 10 to 12 or the 1 to 3 in the afternoon. Okay? So we'll just look at one example here, and it's going to be tough for you to see, so I'll highlight. So here's the 4 drugs we have. We've got Bumex, we've got Lenoxin, we've got Diaman, and we've got Inderol. Okay? So for box 1, down at the bottom here, it is showing an X in front of the sympathetic nervous system. So out of those 4 drugs, Bumex, Lenoxin, Diaman, and Inderol, which of those is going to create an issue or is going to stop activity at the sympathetic nervous system? You didn't think I was going to let you get out there without answering a question. So which of those 4 agents, Bumex, Lenoxin, Diaman, and Inderol, impacts the sympathetic nervous system? Yell loud and proud. You guys are this.
one thing I'm fine with awkward silences, so I can stand here for a while. Who said cardiology? Cardiovascular therapeutics. Nobody? Is that true, faculty? Nobody even hears that cardiovascular therapeutics? All right, take a guess. 1 in 4 chance. Awkward silence commences. Come on, guys. We got 300 of you here. Somebody take a game. I'm going to walk out and hand a microphone to somebody. Student engagement, right here. Get them engaged. The amount of lack of eye contact with you right now is palpable. All right? All right, we're going to go back here. So that's a problem. Okay. Student engagement. All right, so it's UMass, Lanoxin, Dialan, or Indrol. Which one impacts the sympathetic nervous system? Got it. All right, so the point of this was, well, that was kind of a struggle even to get that out of it, right? But as a group, you would be forced to come up with that answer. All right, so Inderol, a beta blocker, impacts the sympathetic nervous system. So what we do with this educational game is, Inderol, box 1, code is 0. So your first code would be 0. They have to answer all 4 of those mechanisms to get the code to get them to the next room. So that was a struggle, right? Trying to figure that out. So it could take a group a little bit of time to figure out how are they going to come up with that code so that they can move on to the next group. And again, you can build it. So this is all about where drugs work, right? This particular one was. Another one is, we got a picture of Superman showing with an arrow down to this wimpy looking smiley face. And then we give everybody a list of statins. And they have to figure out that we want them to rank them for which one's the strongest, to which one's the weakest, to again come up with a code. So you're trying to rank order medications. We've done activities like this where we give them medicinal chemistry structures that they have to figure out what drug is this to come up with a code. All right, so these types of escape groups, students love them because it forces them to work in groups and come up with answers, and it gives them real feedback quickly. Because right away they know, oh, we messed it up. Because if they don't move on to route 2, they know they missed one of these, and they have to go back to the drawing board and try to come up with what's going to work for them. Okay? Another educational game we utilize is Jeopardy. Everybody familiar with Jeopardy? Yep, you get points for how many questions, or whatever question you answer. So this is what we utilize for our students at the end of learning about laboratory values. A super exciting topic, laboratory values. So what we do here is we break the class and usually into 3 groups, and whoever raises their hand first when the clue comes up, they get the opportunity to answer that particular question. So for one of these questions here, if we were able to click on abnormal lab values for 500, it says, this is the upper limit of norm, or this is considered an abnormal value for sodium. So the groups would have to talk amongst themselves. First one to raise their hand would get a chance to answer it, and they would say sodium greater than 145 milliequivalents per liter would be considered high. Correct answer, that you would get 500 points. Okay. They miss it, they lose 500 points. All right, so it's a battle between those groups to prove we know our lab values, and we know what's abnormal, we know what's normal, we know about the CDC, we know about the EMD, and probably the one that's most scary for students is pharmaceutical calculations. And having to calculate a creatinine clearance or an adjusted body weight, we force them to do that as well. So again, it forces them to take something that's normally uninteresting and tries to get them engaged and involved through a gaming opportunity. Now, there are some barriers to integration with these games. One, faculty time and resources. You got to make sure you have the time and you have the ability to pull it off within your course. And you got to make sure you've got time built in with the curriculum to allow these types of opportunities because they help to reinforce and you can also integrate the material here. And then again, you have to make sure the faculty believe that it's actually relevant for that particular topic and that the students would find it relevant. So we usually will survey students after we do these types of experiences to make sure they felt like it was beneficial. If we get feedback from students that they didn't learn anything, then we're probably not going to continue with that activity. But these are two that our students have really enjoyed, they've really taken to, and they've allowed us to continue to evolve with them through the years. All right, the fourth point I want to make, 4 to 5, curricular outcomes and entrustable professional activities. This is probably something that students are not going to find super exciting, but faculty really need to focus in on this, and hopefully from a student perspective, it'll allow you to understand where these types of things come from. So, educational outcomes are considered components that students should be able to do when they graduate. And within the US, we have subdomains. So, all of these subdomains are things that students should be able to do when they graduate. So when you're designing a curriculum, when you're revising a curriculum, when you're integrating a curriculum, you want to make sure that you're hitting on all of the educational outcomes that are required for students to go out and practice appropriately when they're done. So the subdomains we use in the US are scientific thinking, which goes back to the integrated component. It's arguing that students should be able to take the foundational components and tie them into their clinical judgment, clinical decision-making process. Other subdomains, problem solving, communication. We need to enforce cultural and structural humility, person-centered care. We want our students to be advocates, not only on like a legal level, but for our patients, right? We want them to advocate for our patients. Medication use process stewardship. One of the big hot topics in the US, interprofessional collaboration, making sure multiple disciplines are working together. Medicine, nursing, pharmacy, dentistry, we should all be able to work together in specific scenarios. Leadership, we want our students to be leaders, we want them to be self-aware. And one of the things we struggle with, we want them to be professional. Right? Our students have really declined over the last 5 to 10 years in their level of professionalism, and we really had to harp on that within the curriculum to make sure students understand what professional behavior is and how to professionally interact with patients, other healthcare providers, with other students, faculty members. So these subdomains are what students really should be able to do when they graduate from a school of pharmacy. The entrusted professional activities, I'm not going to read through each of these, are a little bit different. These are the activities that you should be able to do after your level 500 courses when you go out to your experiential rotations. So the argument is that students can't do these 13 things on these 2 slides. They should not go on experiential rotations because they are not capable of functioning in the role that we want them to function at when they're out practicing. So again, like I said, I'm not going to highlight each and every one of these, but what I do want to highlight is that the first 10 all go back to the pharmacist patient care process. And that's a list of 5 steps that all pharmacists should be able to do when they take care of a patient. They should be able to collect data, they should be able to assess data, they should be able to create a plan, they should be able to implement that plan, and then they need to make sure what they did was right. They need to follow up through monitoring and evaluation of what that recommendation is. Okay. So why did I highlight this? These were just updated in 2022, and a lot of schools of pharmacy right now are readjusting their assessment tools to make sure students can complete all of these entrustable professional activities before they go out on rotations, and then to make sure that they've addressed all of the education to act in the room. And so we tell them they should be pacing around the room, they should be talking to people they're hearing or seeing in the corner of the room that aren't there, but they need to be pleasant. Try not to scare the students. They should not be aggressive. They should not be threatening. All right? We don't want to drive the students to crying in the middle of the simulation. The ST is also told they need to ramble and mumble throughout the scenario while talking to the voices in their head and those people that they're seeing in the corners of the room, just to get to emphasize that they're going through an actively psychotic episode with their schizophrenia. And maybe most importantly, we tell the ST when they come in, when you're doing these types of simulations, timing is very important. We tell them to hit a timer when the students walk in the room at 5 minutes. And the first thing they're supposed to tell the student is, I need to have this done in 5 minutes because my ride's coming. So what do? If the student gets to 5 minutes and that timer goes off, the ST is told that they're just supposed to get up, say bye, and walk out of the room. All right? If you were a student and you were counseling a patient, and you had a patient just say bye and get up and walk out of the room and freak you out, our students are terrified of that, right? So they're worried about being in a very uncomfortable situation. So they are forced to think quickly. They want to be done in 5 minutes. All right? They don't want that simulated standardized patient to just walk out of the room in front of them. And it's happened before, and the looks you get on students' faces is just incredulous, right? They're like, I don't know what to do here. Now, what that also did, there was one time about 3 or 4 years ago where we had a student grab the patient as they were walking out of the room and tell them they couldn't leave, right? Can we do that? No. Absolutely not. That was something I never would have thought of when developing the simulation, but it's become a major teaching point. You are not allowed to lay hands on a patient, all right, unless they ask you to, or unless you're performing CPR on them, right? So building these simulations, you can build them to be as specific as you want them, but you're, as a faculty, you're still going to learn something that you'll have to highlight later on. Additionally, we tell the standardized patient that there's 3 questions they have to ask. It doesn't matter when they ask them during the simulation, it doesn't matter what order, but they have to ask them. 1, will my dose of olanzapine stay the same forever? So that's really just designed to get the student to say, well, maybe, maybe not. Right? It's one of those questions where it's not a yes or no answer, because we don't know what's going to happen down the line. But it forces the student to counsel them on, we're going to give this a good couple of months to see how we're doing from a dosing perspective, and then we're going to reassess. The second question is, I cannot lose control of my diabetes. Will the olanzapine cause issues with my diabetes, and how should I manage this? So this is planted in a situation because can olanzapine impact diabetes control? Absolutely. Absolutely. So we don't want the student to say, oh no, you'll be fine. It won't do anything to your diabetes control. We want them to counsel them on, well, it could, technically, it could increase glucose production and lead to hyperglycemia. But this patient has very well-controlled diabetes. So the argument is they should counsel the patient on just trying to attempt to keep good control of their diabetes, and we'll monitor it closely as they move on. And the third question is, why are they giving me IV olanzapine for the rest of my life? Now, why do we do this? It's not IV, it's PO. So what's the point of this? It's making sure the student actually read the scenario, okay, before they came in. All they're supposed to counsel on there is, oh, that must be a misunderstanding. It's actually 5 hours. We're going to keep it 5 hours from that perspective. Again, if the timer goes off, they have to just get up and walk out of the room. But if the student finishes early, they just say thank you for that information you provided and allow the student. And from a faculty perspective, when you're developing these simulations, it really needs to focus on, what do we want the student to take away from this experience? So, is the clinical knowledge behind knowing how to treat a schizophrenic patient important? Absolutely. Is that the focus of the simulation? No. For us, the focus is, was the student empathetic? Were they professional? Did they maintain control of the situation? The kid that grabbed the patient walking out of the room did not get a high score on that one. Right? They didn't maintain control of the situation. The student communicated appropriately, both verbally and non-verbally throughout the simulation. And then the bottom one, you can see those are 4 points that have nothing to do with clinical topics. The 5th one is, so the student provided appropriate counseling points throughout the simulation. So we've now been able to highlight what we want the student to get from the simulation. And this is a relatively simple one to pull off. But it forces the students to get out of their comfort zone a little bit and to be able to counsel a patient that maybe would be a little bit intimidating to them if they went out into clinical practice. All right, so that highlights the main insights of how pharmacy education is changing and what you might see over the course of the next couple of years or your lifetime within pharmacy practice here in Uganda as well. So conclusions, pharmacy education is ever changing. Don't be afraid of change. And that goes to both students and faculty, right? Sometimes us just continuing to do what we've always done is not the right move. And we have to be willing to step outside of our comfort zone as faculty to build some of these newer experiences that hopefully draw students back into being more engaged in the classroom. Be willing to take some chances with educational techniques if you believe it will ultimately benefit the students. But again, it's really geared towards faculty. If we feel like we are ultimately benefiting students, that's the ultimate ideal. And last but not least, teaching and in the classroom, it doesn't have to be boring for either the educator or the student, all right? You can make it interesting. Students can make it interesting, faculty can make it interesting. Really just try to be exciting and innovative as much as is possible within the classroom setting because it makes everybody's life more enjoyable, both for faculty and for students. When you can walk into class knowing you're gonna have fun and learn something, that's the ultimate key, right? Okay, with that, I was told I had an hour, and I'm at 59 minutes and 57 seconds. That's pretty good. In 3 seconds. So with that, I would like to thank you for your attention. Hopefully you were able to learn some things, and we'll open it up for some questions.